I also want to acknowledge that I am in Vancouver right now, and I'm on the land of the Musqueam, the Squamish, and the Tsleil-Waututh. And today I've been tasked, and I'm just going to be timing myself if you see me look over. I've been tasked with talking about stigma and intersectionality with a focus on the health and well-being of women living with HIV in Canada. And yeah, I hope you are following the podcast, and you can also follow me on Twitter. So the overview of my talk today, I'm first going to talk about how we can conceptualize intersectionality and stigma. Then I'm going to present two case studies applying intersectionality to research with women living with HIV in Canada. And I'm going to conclude by talking about considerations for moving forward. So what do we actually mean when we talk about intersectionality? I want to bring us back to the Black feminist collective, the Combahee River Collective, and their statement, which is widely known as a precursor to what has been now called intersectionality, I think is worth reading. We're actively committed to struggling against racial, sexual, heterosexual, and class oppression, and see as our particular task the development of integrated analysis and practice based upon the fact that the major systems of oppression are interlocking, and this synthesis of these oppressions creates the conditions of our lives. So intersectionality was termed and conceptualized by Black feminists, but even before the Combahee River Collective, Sojourner Truth in the 1800s, in A&I Woman is a very well-known statement about the intersection of race and gender that produces a particular experience of marginalization. And today I'm fortunate to work a lot with Dr. Lisa Boleg, and she has really brought intersectionality into a lot of stigma research and discussions around how to do intersectionality in research. And what I want to note from her description of what is intersectionality is that she talks about it as a theoretical framework that looks at how multiple social categories such as race, gender, and sexual identity intersect at the individual level of experience to reflect systems of privilege and oppression that are occurring at the macro or at the social and structural level. For instance, categories such as race can be experienced as racism, gender as sexism or gender discrimination, etc. And so when we think about stigma, it's also a complicated and very vague term at times, and it's multi-level. So it's not only something that's experienced internally, it's experienced relationally in our interactions with others. It's experienced in communities, and it's experienced in systems and institutions. And so today I'm going to be focusing a lot on structural stigma, and it's the way that policies, institutions, and norms and ideologies constrain opportunities, resources, and well-being. And when we focus on the structural dimensions of stigma, it moves us from thinking about the problem lying within individuals to looking at the root cause of the problem in our social, economic, and political environments. And I want to bring us back to Lincoln Fallon, who talked about stigma and power. So I think that this is something that I'm going to be talking a lot about today, but the way that stigma operates to keep people down, to keep people in, and to keep people away. So keeping people down is domination and exploitation. We see this in current and historical slavery and colonization. Keeping people in, so formal and informal rules and punishments for not abiding by social rules and norms, and keeping people away. And this is often found when people are perceived visually to be sick or unwell or unhealthy. There's a lot of distancing, and that is some thing that, we can think about it with a lot today with regards to HIV and also to COVID-19 and to other illnesses where people are maybe avoiding people. So when we put together these ideas of stigma and these ideas of intersectionality, we come to the concept of intersectional stigma. And I want to also recognize an African-American woman author, Michelle Tracy Berger, who coined the term intersectional stigma in her book, Workable Sisterhood, in 2004. And as part of work that I've been doing for a long time, let's say 15 years with Dr. Mona Lutfi and others, and Wangari Thoreau, we did a women's community-based research project where I was lucky enough to do focus groups in 5 cities in Ontario, and we developed this conceptual model of intersectional stigma. And you can see some of the examples of the stigma that were highlighted that are relevant today. So as Maureen, and I appreciated Maureen's presentation and her call to say, why is stigma persisting? And I hope that, we can talk about some of the root causes of stigma that we're not addressing, which is perhaps why we still see the persistence of these exact forms of stigma today. And this is sex work stigma, racism, homophobia and transphobia, sexism and gender discrimination, and HIV stigma, among others, of course, and how these are experienced at the micro level, the meso and the macro. And when I conclude today, I'm also going to bring us to this slice. It might look like a slice of pie in the left side of the model, which is around coping. And so how coping also exists at the same time as stigma, and it also spans interpersonal and individual level, community level, and structural levels. And more recently, I'm part of National Institute of Health in the US working groups on stigma. And for part of a special issue, the BMC Medicine, we led by Dr. Janet Turan, we sort of mapped out some ways to think about intersectional stigma moving forward. And so we've also been thinking about how do we create a model of stigma that integrates many health issues, or that could be used across health issues, that doesn't just look at psychological processes, which of course are important, but many of those models don't necessarily integrate the social and structural pathways to and from stigma, or include intersecting identities. And a lot of these models posit that people are either stigmatized or stigmatizers. But from an intersectional perspective, we hold many identities, and some of those may be identities that hold more privilege, while others may be more marginalized identities. And so this is a conceptual framework that we came up with, and this was a lot of work because we had people who are epilepsy stigma researchers, mental health stigma, substance use stigma, HIV stigma, LGBTQ stigma. So we came up with one model that we hope can be applied. It's called the Health Stigma and Discrimination Framework across health issues and contexts. And I'm not going to go into it in depth, but just to say that we really tried to think about the root, the base of stigma, which are in drivers and facilitators. And these drivers include stereotypes, prejudice, fear, a lack of awareness, but they also include facilitators that could be positive or negative in relationship to increasing or decreasing stigma. And those include the legal environment, health policies, social and gender norms, and cultural norms. And then these results in stigma being marked on people based on health conditions and or social identities and practices. And it's manifested in the various experiences, whether that's discrimination, anticipated, perceived stigma, internalized stigma, and that has many different outcomes, including access to justice, right to health, engagement in the HIV cascades, and ultimately in health outcomes. And so I'm going to present 2 case studies of how we've been applying intersectionality to thinking through research with women living with HIV. And they're examples from the CHIVO study, which is led by Dr. Mona Lutfi, Dr. Alexander Pokomandi, and Dr. Angela Kaida. But I first want to do a quick walk through what we have done to date, because we've done quite a bit to date. And this is a recent study in social science and medicine where we looked at how can we understand intersectional stigma. There's a lot of debate in how we measure intersectional stigma, for instance, quantitatively. And so we looked at a latent construct where we looked at HIV stigma, racial and gender discrimination as a latent construct, and pathways to HIV outcomes via social and structural factors, such as social support and access to women-centered care. And we also did this in another model where we looked at HIV stigma, gender and racial discrimination separately. We've also looked at pathways from HIV stigma, racial and gender discrimination to physical and mental health related quality of life, also through mediators of economic and so insecurity and social support. So really trying to look at the social and structural factors that might be partly causing the harms from stigma to well-being. And this is also quite recent, is a study we did that looked at how HIV stigma, racial discrimination, gender discrimination are associated with increased exposure to violence among women living with HIV. And we used longitudinal analyses to really demonstrate that HIV stigma is associated with increased exposure to recent violence among women with HIV. And over time, that harms mental health and well-being. And so I really want to bring us back to this discussion of stigma power. So often the power structures behind stigma are overlooked, yet stigma is embedded in social systems that decide who is valuable, who is worthy. And these power systems can be internalized and they can also be invisibilized. And so this is hidden in our social and cultural values, norms, and beliefs, and also in our laws, our institutional practices, and negative social contexts. So this is relevant to the two examples I'm going to give today. So the first is some recent analyses that we've conducted looking at sex work and the relevance of intersectionality to understand the well-being among women living with HIV in Canada. And we know, and many of you on this in this meeting have done work with sex workers, and we understand that sex workers experience marginalization in a large part due to the social and structural context of stigma and criminalization. These elevate exposure to violence, arrest, and incarceration. And stigma towards sex work intersects with stigma towards HIV, towards gender-based inequities, towards racism, towards poverty stigma. And so we wanted to look at the longitudinal associations between sex work and other outcomes, including stigma, psychosocial, and clinical HIV outcomes among women in Canada living with HIV. And so this is part of the CHIBO study, the Canadian HIV Women Sexual and Reproductive Health Cohort Study. And these findings are in revision right now. Fingers crossed, you'll see them out soon. And we looked at recent, so the past 6 months sex work prevalence and associations with these various outcomes that I mentioned. And we found that actually sex work is not uncommon. So, and it changed over time. So I'm not presenting the full, for the sake of time, I'm not presenting the full results here. Happy to share with those who are more interested. But we found out of 1,422 people, 9.1% reported sex work during at least one of the three waves. And that changed over time. So suggesting that sex work is dynamic among women living with HIV. Some people move in and out of sex work. And I'm going to talk about why we adjusted for province, age, income, gender identity, sexual orientation, education, ethnicity, and housing insecurity shortly. But in this adjusted analyses, we found that recent sex work over time was associated with violence, injection drug use, recent violence, recent injection drug use, hazardous alcohol use, and depression. And in unadjusted analyses, it was also associated with gender discrimination and HIV clinical outcomes. And this is what is also important to think about, is that the women living with HIV who are engaged in sex work were more likely to be transgender than cisgender, lesbian, bisexual, and queer versus heterosexual, have a less likely to have a high school education, be younger, more likely to identify as Indigenous than other ethnicities, were less likely to have secure housing, and were more likely to have a lower income. And this is the results I shared earlier, where you see experiences of violence being nearly 2.5-fold higher among those reporting recent sex work, injection drug use nearly 3.5-fold higher, hazardous alcohol use twice as high, and depression 1.5-fold higher. So when we're thinking about intersectionality and we're thinking about sex work among women living with HIV, as I mentioned, a queer woman, trans women, lower income women, Indigenous women, and housing insecure women were more likely to report sex work. And those who reported sex work in wave 1 were more likely to be lost to follow-up. And the lost follow-up were more likely to identify as Indigenous, trans, lesbian, gay, bisexual, or queer, unstably housed, and low income. So this fact that we found that sex work was associated with violence and with health inequities requires a syndemics lens. And I write still because we've been talking about syndemics, about co-occurring social and health disparities in the context of HIV for 2 decades. So I want to echo what Maureen said about why have things not changed? And I think, what I've already said has highlighted the need for an intersectional perspective here that considers many different identities and social marginalizations and really calls for the need for structural change. So the work of many people in Canada and globally has highlighted that we need to decriminalize sex work. We need to promote human rights towards sex work. We need to reduce sex work stigma as well as HIV stigma, as well as all the other intersecting forms of stigma, in order to really get to the root of why are these social and health disparities experienced among sex workers in general and among women living with HIV engaged in sex work. The second example I want to give today about intersectional stigma among women living with HIV is asking the question, does poverty drive HIV stigma among women living with HIV? So this is brand new analysis that we've conducted. It's in review. And what I want to talk about is that there's a great evidence base, and we've in Canada and in other high income countries, as well as low and middle income countries, that people living with HIV are more likely to experience social inequities when it comes to food and housing insecurity and poverty. And in Canada, there's some research that's been done that shows that the out-of-pocket costs for publicly funded health services, including antiretroviral therapy, varies, and people may need to apply for social assistance to access comprehensive coverage. There's also limited income from social assistance. People are often working in low-wage employment, and there's also illness-related loss of income. And all of these converge to produce challenges acquiring and maintaining a sufficient and reliable food and housing. As I mentioned, this is not unique to Canada. Other high-income contexts, such as the US, the UK, and Australia, have also noted that there's food and housing insecurity, low income, and unemployment that are disproportionately impacting people living with HIV. And so we know that there's HIV stigma, we've established that. Well, there's also poverty stigma. So people who are living in poverty are also stigmatized, and I'm putting this in quotations, as being a quote failure, quote lazy, quote irresponsible. And I want to suggest that this is part of stigma power, where people from higher classes are keeping people down below them, and where healthy people are quote keeping people who are perceived as less healthy or not able to fully engage in the workplace away. And this is termed the pathologization of poverty. So for instance, when people who are receiving disability-related benefits are stigmatized, this is actually rooted in local moral economies, where work and being formally employed is valued and unemployment is socially devalued. And interestingly, when I was looking at various meta-analyses, I found that the one that I did as a PhD student in 2009, was the one that I found that actually included HIV stigma as being associated with lower income. And so we know that this is actually out there in the literature, but there's very little longitudinal data looking at poverty as a driver of HIV stigma. And so we've already documented that there is food and housing insecurity as a crisis among people living with HIV in Canada. And we've done this with the CHIWOS cohort. And so for this analysis, we looked at food and housing insecurity over time, and if they were predictive of HIV stigma outcomes. And so this, if you leave this talk with one thing today, if all you remember is one thing when you walk out, I want you to know that it's a crisis. 1/3 of the women living with HIV reported food insecurity and 1/10 housing insecurity. So if this is all you remember from this talk, I want you to remember that this is something that requires urgent attention. So what we found was HIV stigma scores were consistent across waves 1 and 2 and lower at wave 3. And food insecurity at baseline was linked with higher HIV stigma across all 3 waves of data collection, and housing insecurity was linked with higher HIV stigma at waves 1 and 2. And I want to note that HIV stigma at baseline was higher among lesbian, bisexual, and queer women, Black and Indigenous versus white women, and younger women. So these were adjusted for in the analyses. So on average across time, food insecure people reported HIV stigma scores 8.6 points higher than food secure, and people in insecure housing experienced HIV stigma 6.2 points higher over time. And you can see the figures here. So while the food insecurity, while all the HIV stigma scores declined over time for wave 3, there was still a significantly higher HIV stigma at wave 1, 2, and 3 for food insecure, and at wave 1 and 2 for housing insecure. So we really see this is intersectional stigma at the nexus of poverty and HIV, and that is structural arrangements such as ARG coverage, inadequate social assistance, inadequate employment that meets the needs of people living with HIV, create unequal social hierarchies. And poverty is relational. So it's how people are treated in social in institutions when people are going to get assistance, when people are relating with one another, but it's also a core experience of disempowerment, suffering, and struggle. And people living with HIV can be judged for both being ill and for receiving social assistance. And so, as I mentioned, if all you leave with one thing today is the urgent need to reduce both poverty and stigma. And so I also just wanted to note that there is HIV stigma is not experienced the same. And so we need to really get to the root of why are lesbian, bisexual, and queer women and Black and Indigenous women. And I think we know why they're experiencing higher HIV stigma is because their experiences of stigma are exacerbated by pre-existing stigma based on racism and based on homophobia. And so there's, a lot of people have been writing about this, including our study that came out a couple of years ago. And we need to move beyond writing and documenting the issue to actually addressing it to reduce the social and health disparities experienced by people living with HIV and the examples I gave today among women living with HIV. And so this combination, this mixture of poverty and violence and HIV and intersecting stigma really produce this structural violence that limits the ability for people to realize their full opportunity in life and to realize their potential. And you can imagine what we're missing when people can't realize their full potential. And so I'm going to end on an uplifting note, don't worry. So I'm going to bring us into a space of hope and celebration right now, because I don't want you to think that it's only a sad story, and neither do the founders of Intersectionality. And so I'm going to come back to this scoping review where we looked at this very recent, just published this year, how have people that have been doing intersectional stigma research been thinking about empowerment-based perspectives, and why does this matter? Well, this is a really long quote. I'm not going to read it all, but I do want to talk about Dr. Kimberly Crenshaw, who actually is the person who is widely known for being one of the key people who coined the term intersectionality. She talks about that race, gender, and other forms of identities are often associated with these ideas of bias or domination, what she says as intrinsically negative frameworks in which social power works to exclude or marginalize those who are different. Yet what is missing, she is saying here, is that the view that the social power in delineating difference need not be the power of domination. It can instead be the source of social empowerment and reconstruction. So just because there is racism, it doesn't mean that there can't also be positive and empowering experiences and qualities and strengths for racialized people. Just because there's homophobia and transphobia doesn't mean that LGBTQ people don't also experience solidarity, strengths, and pride. So it's not just because there's oppression doesn't mean there's not equally the opportunity for empowerment. And, you know, what we measure matters. And so we found that in our review, that only 13 out of 32 studies looked at any empowerment-based factors. And most of those were at the interpersonal level, such as social support, and at the individual level, such as resilience. But there is also the need for us moving forward in our research to look at community factors of empowerment and strength, such as social cohesion, collective efficacy, community connectedness, solidarity, and structural factors such as activism, woman-centered HIV care, which I know a lot of people here, including Dr. Melanie Murray, Dr. Mona Lutfi, Dr. Nayara Pick, have been focusing a lot of work on woman-centered HIV care, and policy change and activism. I also want to encourage us to research for desire. Dr. Eve talked about moving beyond a damage-centered research towards desire-based research. So what she said is, I want to join you, I invite you to join me in re-envisioning research in our communities, not only to recognize the need to document the effects of oppression, but to consider the long-term repercussions of thinking of ourselves as broken. Desire-based research frameworks are concerned with understanding complexity, contradiction, and the self-determination of lived lives. So moving from damaged perspectives to desire perspectives, and to complexity and self-determination. And finally, I want to encourage us to think about sexual justice and flourishing. So sexual justice is about equitable, person-centered sexual and reproductive health experiences. And I want to remind us that sexual health, as defined by the World Health Organization, includes freedom from sexual and gender-based violence, which I have noted in some of the examples today. We've been mapping onto experiences of stigma and discrimination. So in order for people to realize sexual health and reproductive health, they also need to be able to live lives free of violence, coercion, and discrimination. We need a trauma-informed, sex-positive approach. We need to look at how sexuality and sexual expression contribute to overall well-being in life. And I'm going to give you a spoiler alert for the last sentence in my book. If you want to read the book, let me know, is about flourishing. And I pulled it from the Merriam-Webster dictionary, which means to grow luxuriantly. Moving beyond ideas of resilience, which is grounded in ideas that we have to bounce back from a hardship. So it's in relationship to hardship. What if we just talked about flourishing, growing luxuriantly? And there's been some wonderful work that's just come out this year on the concept of flourishing. And this is from an article in BMJ Global Health, who defined flourishing as an active process of striving to live in keeping with one's defining values, commitments, and vision for the future, both as individuals and in the context of family and communities to which one belongs. So how can we hold both the stigma, the intersectionality, and striving for sexual justice and flourishing? So this is my last slide, encouraging us to all think about balancing the tensions between focusing on stigma and focusing on agency, resistance, looking at all of these different manifestations of stigma at structural, community, relational, and interpersonal dimensions, and how people are kept down in and away, and moving towards flourishing and desire-based research so we can really maintain a critical hope while we try to transform the social world around us. I just want to thank you for inviting me to be here, all of the funders, and of course the CHIWOS PIs. Follow me on Twitter. There's my book. Listen to the podcast. Thanks for having me, everybody.